Hello guys, welcome to our channel Easy Drug. Today we see a topic about bone and joint infection. Osteomyelitis, an infection involving in the bone or bone marrow. Vertebral osteomyelitis, an infection involving the vertebral bone. Most commonly, native vertebral osteomyelitis, infectivous arthritis, an infection of one or more native joints that can be caused by bacteria, virus, fungi, and parasites. Septic arthritis or bacterial arthritis, infection in the native joint which are caused by bacteria. Prostatic joint infection, an infection in the prostatic joint. The most common clinical features of native vertebral osteomyelitis is back pain, fever, neurological impairment like sensory loss, weakness and radiculopathy, and tenderness of spine. In prostatic joint infection, joint effusion, fever, erythema and warmth at the implant site. These are the common clinical features of this native vertebral osteomyelitis and prostatic joint infection. The most common organism that cause vertebral osteomyelitis are Staphylococcus aureus, E. coli, coagulase negative staphylococci, streptococci, enterococci, Pseudomonas aeruginosa, enterobacteriales, and Propionibacterium acnes. In prostatic joint infection, the most common organism that cause prostatic joint infection are Staphylococcus aureus, which cause 21 to 43% of prostatic joint infection, and coagulase negative staphylococci, which cause 17 to 39% of prostatic joint infection. Streptococci, 7 to 12% of prostatic joint infection are caused by streptococci. Gram negative aerobic bacilli, which cause 5 to 12% of prostatic joint infection. Enterococcus, 1 to 8% of prostatic joint infection are caused by enterococcus. And finally, anaerobes, 2 to 6% of prostatic joint infection are caused by these anaerobes. In vertebral osteomyelitis, most commonly it is caused by Staphylococcus aureus and E. coli. An empirical therapy for osteomyelitis. While we choosing empirical therapy, we should choose the antibiotic which should cover the MRSA, streptococci and gram negative bacilli. So these are the antibiotic we choose as an empirical therapy to treat osteomyelitis, like vancomycin and third generation cephalosporin, vancomycin and fourth generation cephalosporin, vancomycin carbophenam, and daptomycin fluoroquinolones. While we choosing vancomycin plus third generation cephalosporin, ceftriaxone is a third generation cephalosporin which should cover gram negative and streptococci, but it won't cover Pseudomonas. While choosing ceftazidime which covers Pseudomonas. So if a patient having a risk of Pseudomonas, we should choose ceftazidime along with vancomycin. If a patient does not have a risk of Pseudomonas, we should choose ceftriaxone plus vancomycin, and vancomycin plus fourth generation cephalosporin. Generally, cefepime is used. Then vancomycin plus carbophenam. More drugs are resistant to Pseudomonas, so that time we should choose carbophenam. But ertapenem won't be chosen because ertapenem will not cover the Pseudomonas. So except ertapenem, we should choose other carbophenam along with vancomycin and daptomycin plus fluoroquinolones. Fluoroquinolones are generally used for the patient who have beta-lactam antibiotic allergies. For those patients, we should choose fluoroquinolones. Daptomycin is used for the patient who are not tolerated vancomycin. For those patients, we should use daptomycin. Pathogen specific therapy. Most commonly, methicillin sensitive Staphylococcus aureus (MSSA). The first line drug of choice is nafcillin, oxacillin, ceftazolin, and ceftriaxone in IV form. If the alternative therapies are vancomycin in IV, daptomycin in IV, linezolid in IV or oral, then levofloxacin plus rifampin in oral form, and clindamycin as IV form. We use vancomycin for patients who had developed type 1 or delayed allergic reaction because of this beta lactam antibiotic. For those patients, we use this alternative choice. Then MRSA, methicillin resistant Staphylococcus aureus. The first line choice is vancomycin in IV form. Then alternatives are daptomycin in IV form, linezolid in IV or oral form, levofloxacin plus rifampin in oral form. For MSSA, beta lactam is more effective over vancomycin. For MRSA, beta lactam is not effective. Then Enterococcus, penicillin susceptible. So the first line choice is penicillin G and ampicillin in a IV form. The alternatives are vancomycin, daptomycin and linezolid in IV or oral form. We use vancomycin for patient with penicillin allergy. Enterococcus penicillin resistant. The first line choice is vancomycin in IV form, and alternatives are daptomycin in IV form or linezolid in IV or oral form. Then Pseudomonas aeruginosa. The first line choice is cefepime in IV, meropenem and doripenem in IV form. The alternatives are ciprofloxacin in IV or oral form, ceftazidime in IV and azithromycin in IV form. We use azithromycin for patients with severe penicillin allergy and fluoroquinone resistant patient. For those patients, we use azithromycin in IV form, in IV and ertapenem in IV form. Then alternatives are ciprofloxacin in IV or oral form. Then beta hemolytic streptococci. The first choice is penicillin in IV or ceftriaxone in IV form. The alternatives are vancomycin in IV form. Then Propionibacterium agnos. The first line choice is penicillin or ceftriaxone in IV form. The alternatives are clindamycin or vancomycin in IV form. Then Salmonella. The first line choice is ciprofloxacin in IV or oral form, or other alternatives are ceftriaxone in IV form. In Brucella species, the first line choice is doxycycline plus streptomycin. So the duration of doxy is 3 months and the duration of streptomycin is 2 to 3 weeks. And while we using doxycycline plus rifampin, the both drugs to be used for 3 months. So the duration of antimicrobial therapy for bacterial native vertebral osteomyelitis, the total duration is 6 weeks of parenteral antimicrobial therapy. And for Brucella species, the duration of antimicrobial therapy is 3 months. Then treatment of prostatic joint infection. So as we see in earlier slide, prostatic joint infection means infection in the prostatic joint. So the prostatic joint infection following debridement and retention of prosthesis, which is caused by staphylococci, we use pathogen specific if it is methicillin sensitive staphylococcus aureus or methicillin resistant staphylococcus aureus. We use the pathogen specific antimicrobial therapy in IV form along with rifampin 300 to 450 mg oral twice a day for 2 to 6 weeks, then followed by oral antimicrobial therapy plus rifampin 300 to 450 mg oral twice a day. The oral antimicrobial therapies are levofloxacin that can be used. Then the durations of this therapy: 3 months duration for total hip arthroplasty, elbow arthroplasty, shoulder and ankle arthroplasty, and 6 month duration for total knee arthroplasty. See here, the silver color you are seeing, no, this is the prosthesis. So see here, this is prosthesis. Then here the red color, this is a bacterial biofilm and this is bone tissue. You know, in this biofilm there is no blood or microcirculation inside the biofilm to deliver antibiotics. in the biofilm, microbes are protected from antimicrobial agent, and these biofilms are mostly formed by staphylococcus, and sometimes it is also formed by pseudomonas. Only antibiotic which can enter into this biofilm are rifampin. If that prostatic joint infection caused by other organisms, we should use the pathogen specific antimicrobial therapy in IV form for 4 to 6 weeks. The pathogen specific antimicrobials are already seen in the previous slides. If the prostatic joint infection following resection arthroplasty with or without reimplantation, for this we use that pathogen specific antimicrobial therapy for 4 to 6 weeks. Here no rifampicin is used. Rifampicin not needed here. Then prostatic joint infection following amputation. So we use pathogen specific antimicrobial therapy for 24 to 48 hours after amputation. Then pathogen specific antimicrobial therapy can be used for 4 to 6 weeks if despite surgery there is residual infected bone and soft tissue. The oral beta-lactam should not be preferred for the initial treatment of native vertebral osteomyelitis because of their low bioavailability. Then oral vancomycin is not absorbed, so it should not be used for any systemic infection. Only oral vancomycin is used for Clostridium difficile infection in GI tract. In previous slide, I said like oral antimicrobial to be used. First parenteral antibiotic to be used, then following week we should use oral antimicrobial therapy. So the oral antimicrobial with excellent bioavailabilities including fluoroquinolones, linezolid and metronidazole can be used.